Welcome back to Skinfluence, the podcast where we discuss everything you need to know about skincare, skin health, holistic, everything.
Everything.
We're trying to just make you look good and feel good from the inside out. And today we're going to be making some rash decisions.
Ooh, not too rash, I hope.
Not too rash, which is like my favorite dad dermatology jokes. Like, why did the dermatologist get fired from his job?
Why?
He was making too many rash decisions. it's so bad.
But it's so good.
So today we're going to talk all about rashes, the different kinds of rashes that we see, and when other providers see a rash in urgent care or the ERs, like it's just red, papulopustular, like they just use these same words, and you're like, it's not any of that, probably.
Yeah. Maculopapular.
Maculopapular, you know.
Classic.
And everybody knows you get a rash, you don't know what it is. Everybody assumes usually it's an allergy, but you know, it's not always an allergy to something.
No, there's lots of different things that can be happening to cause a rash. And very commonly we get sent in with the misdiagnosis. They're already on treatment, and now it's up to us to figure out what it is and fix it.
Yeah, exactly. Or worse, the patient comes in and they don't have the rash anymore, but they tried to describe it. And they're like, what do you think it was? And I'm like, I have no idea.
Yeah. Did you take pictures? Nope.
No. So if you have a rash, it's a good idea to take pictures of it.
It's the best idea to take pictures of it.
In case you get into your appointment and it's gone and you want to prevent it from happening again. It does help us if we can see what it looked like. We're a visual specialty.
Exactly.
So I
tell all my patients, if they have a rash, first thing is take a bunch of pictures, because there's a good chance if you're coming in, we missed it, or it went away.
So a lot of different common types of rashes. We'll start with contact dermatitis, which is what I think most people assume they have when they show up with a red rash that's itchy, is contact dermatitis. This is, I mean, there's technically two types, allergic contact dermatitis and irritant contact dermatitis.
Yep.
And I'll cover allergic contact dermatitis, and then you can talk to us about irritant contact dermatitis. But allergic contact dermatitis happens when something comes in contact with your skin that your immune system in particular does not like, and it creates an immune response against it. But that particular thing might get on somebody else's skin and not cause a problem. And the most common example that we see in the clinic is nickel, as a nickel allergy, which is in inexpensive jewelry, costume jewelry. It's on the back of the snap of your Levi jeans, belt buckles. And when you are allergic to nickel, you'll get a terribly itchy, scaly rash in the area that nickel touches the skin, whereas 90% of people are not allergic to nickel.
Right.
And poison ivy is an allergic contact dermatitis.
Totally.
That most people will become allergic to. Yeah. So it's got a much higher chance of causing an allergic reaction.
Yep.
And neomycin from Neosporin, which we've talked about before, that we hate.
Yeah, we hate
is
it.
Another one that can cause an allergic reaction in a certain percentage of people.
Yeah.
But most people will not develop an allergy to it.
Totally. And gold is surprisingly a very common contact allergen as well.
Yeah.
It's got to be pure gold, though. And you have to have a lot of direct contact with it. But when people do the patch testing, gold's one that lights up.
And that's why I don't wear a lot of bling, because I'm worried about getting a gold allergy. It's not that I couldn't cover myself in gold.
I don't know. I saw the grill you have.
Call the jewelry stolen.
Post Malone, he's not allergic to anything.
No, that guy's not.
Yeah, so a lot of times people come in and they'll have a rash, and the first thing that they'll say is, I switched all my detergent. And which is not a bad move. If you have a true contact allergy, switching to like all free and clear is a good one. I don't know. Do you have any others that you recommend?
Tide free is also good.
Tide free is a good one.
So all free and clear, Tide free. They're just no perfumes, no coloring in there.
Yeah.
So things that are more likely to cause an allergy.
Yeah. But with contact with a true allergy, it'll follow usually a specific pattern. And so when people are thinking, do I have an allergy to my detergent? Well, the detergent got all over the clothes, so it'll be probably all over the skin where the clothes are touching you. Whereas a irritant contact dermatitis is, instead of your body mounting in an allergic reaction, the chemical or whatever's causing the irritation just is physically disrupting the barrier of the skin, causing it to kind of fall apart, turns red, and it gets angry. Irritant contact many times is itchy, whereas, allergic contact is usually more itchy, where irritant can be a little bit more painful and stinging. And so sometimes that's kind of how we can distinguish between the two. But there's crossover, and treatment's very similar.
They can look similar. They can have similar patterns on the skin. The example that I tell my patients is like, if we were both, dipping our hands in gasoline every day, it's going to chew up your skin barrier. It's going to destroy it. It doesn't matter who does that. It's going to cause damage.
Yeah.
And the most common irritant that causes irritant contact dermatitis is water.
Yeah.
It's from
washing
hand
the
washing.
skin.
Yeah.
Yeah. Cement is another surprising one that I see quite a bit. Cement workers come in with that cracked hand dermatitis, and it's irritant contact from the basic cement.
Yeah. It's got a very basic pH, and it just tears up the skin barrier. So
Yeah.
some nuances between irritant contact and allergic contact. And we'll get into the treatment of all of these later on in the episode. And then we have eczema. And eczema is kind of a catch-all term that can encompass contact dermatitis.
Totally.
Yeah, eczema is just a disruption of the skin barrier of some kind. But usually when people say eczema, they really mean atopic dermatitis.
Right. Atopic dermatitis being a genetically inherited condition where your immune system, there's an immune dysregulation, and most commonly due to weather change. So when you get too cold or your skin gets too dry, your immune system doesn't like it, and your barrier breaks down, and you get these itchy rashes all over. In kids, it kind of shows up in like the flexor areas, and then as adults, these little circles all over the body.
Yeah. So we have our skin, if you think of it as a model of bricks and mortar, looking at a brick wall, the skin cells are like the bricks, and the mortar is the material that holds it all together.
Right.
In our skin, the cells are the bricks, and all the lipids, the proteins, there's all this stuff between the cells that hold them together. And one of those important proteins is something called filaggrin. Ceramides are another thing that are in there, free fatty acids and cholesterol. But some people with atopic dermatitis have a mutation in the filaggrin gene. And so that mortar basically doesn't work as well. And they get a crumbly brick wall, so to speak. So the barrier's not functioning. You lose water out of the skin. Viruses, bacteria, irritants, allergens can get in there easier.
Yeah.
And you get that classic area, like you mentioned, on the flexor surfaces, which is classic in children. And then adults getting the more spots, on the legs. We call that nummular eczema.
Yeah, classically diagnosed as ringworm.
Yeah, often. I mean, it's circular. Nummular meaning coin-shaped.
Yeah.
So...
And there's tricks. So when you're coming into the dermatology office, we look for clues. It's kind of like playing a detective, because every rash has its little nuances that we look for to try to distinguish between the two, or between the different ones. Interestingly, contact dermatitis, irritant contact dermatitis, eczema, when we do biopsies, can look very similar under the microscope. So when people get referred over to do a biopsy of a rash, very many times we get the spongiotic dermatitis result, and it's basically showing kind of that barrier dysfunction, and now we have to really ask questions and figure out, okay, what's going on here.
And it can be frustrating for patients sometimes, is they'll be sent in by their primary care doctor, by urgent care, for a biopsy because they didn't know what it was. But we can look at the skin and say, this is following a pattern of nummular eczema.
Yeah.
And we don't need to do a biopsy to determine that. I know that if I do a biopsy, it's going to show spongiotic dermatitis from the pathologist. And then we've charged the patient for a biopsy. They have a scar now from a biopsy, and it doesn't really add anything to our diagnosis.
Right.
I usually, unless something has been going on for months or years for a patient, we don't always biopsy them on the first visit. We'll try some treatment that hasn't been tried before. And then if we're not getting better, then we have to ask, are we missing something? And can a biopsy be contributory to your diagnosis and appropriate treatment?
Totally.
So
another rash that people come in with is hives.
Hives, yeah. And this one is very frustrating because it's often difficult to determine the cause.
It's very difficult sometimes.
So we call hives urticaria, and it is a histamine response in the skin. So we have these cells in our skin called mast cells. It's a version of a white blood cell, and they are just full of, it's like a bomb inside there.
It's ready to explode.
And it's just ready to explode. It's like a Mike Tyson white blood cell. Like you just have to anger it a little bit, and it's just going to explode, and it's going to dump all this histamine out into the space between the cells. And when histamine gets there, it causes the blood vessels to dilate, and then fluid leaks out of the blood vessels, and you get swelling in certain areas.
Yeah.
And it can appear very rapidly, and it can resolve very rapidly.
Totally.
And it's usually quite itchy.
It's usually very itchy. The nice thing, so distinguishing between hives and other types of rashes that we see, because what you're talking about happens deeper in the skin, in the dermis, whereas eczema, irritant contact dermatitis, and allergies happen more in the epidermis, the top layer of skin. One of the clues that we look for are, is it flaky, or is this dermal, or is it just kind of just a dome top, where hives is more domed and not flaky compared to the other ones.
Yeah, we don't see changes on the surface of the skin. It's not scaly, it's not flaky.
Yeah.
And hives, goes into that. Acute hives, which is anything that's been going on less than 6 weeks. We always ask the patient, when you get a hive, how long does it stick around? Because usually hives don't last more than an hour in any one spot. But by definition, hives should resolve within 24 hours. Now, that may mean you still have hives for more than 24 hours, but if you had them on your legs, those disappear, and now they're on your trunk. And, it can be going on all the time, but any individual hive should be going away within 24 hours in most cases.
Yeah. And then if it's going on for more than, it's like you're saying, 6 weeks, where you're getting these hives that are just coming and going, but always there, then it moves into chronic urticaria, and there's, then we have to look into some alternative treatments or things like that. But
chronic urticaria is one of the most frustrating things that we see, because we can do blood workups, we can do biopsies, and still over 50% of the time, the underlying cause is not identified through routine workups.
Idiopathic urticaria.
Idiopathic. And that just means no known cause. It doesn't mean that we are idiots because we don't know it.
Yeah, it feels like it, though.
Sometimes it feels like it. And so there's many different causes for hives. I mean, some people just get it because, it can happen due to foods, whereas eczema, atopic dermatitis has not been strongly linked to foods. I think over time we'll determine that there probably is more food sensitivity issues than we have evidence for right now.
Right.
But hives can be linked to foods. It can be linked to contact, things coming in contact with the skin that don't necessarily cause eczema but cause hives. It can be caused by fluctuations in your temperature. So some people when they get really cold, and some people when they get really hot.
Yep.
So I have a patient right now that generally only gets hives when he works out. When he starts sweating and his body temperature is going up, he breaks out in hives, and it makes it difficult to go to the gym. Some people get hives from vibration, from pressure. So there was a patient that I saw in residency, and they had hives going on for months and months and months. And they would get that every time they got a massage.
Oh, really?
And so initially, and I think rightfully so, they assumed it was the massage oil that was being used. And so they kept going back to the massage therapist, and then they would try different oils, different lotions, coconut oil. They tried to go as basic as possible.
Right.
And they always got itchy and developed hives after their massage. And through workup and everything, we determined it wasn't anything that was getting on the skin. It was the pressure pushing on the skin was enough to degranulate those mast cells and cause that massive histamine dump.
Yeah, pressure urticaria happens. I remember when the high-waisted pants thing in women started to pick up, and that became kind of a trend. We started to see hives across the waistline, kind of by the belly button, from the yoga pants things, the people wearing tighter pants in that area, and that's kind of was a frustrating thing for some.
Yeah, that's why I never wore those kind of pants.
Yeah.
That makes
sense.
I didn't want to risk it.
Yeah, I wouldn't either.
I'm sure they would have looked very good on me. So, another thing we can touch on is psoriasis. Psoriasis is a rash that is in the epidermis. It is scaly. It can be itchy. And whereas eczema usually comes on the front of the elbow, on the flexor surface, psoriasis is usually on the back of the elbow, on the extensor surface, on the front of the knees, on the scalp, on the buttocks, on the back, the trunk. And this one is definitely something that comes with a genetic predisposition, and then there's usually an environmental trigger that sets it off, and then it can be a chronic condition.
Right. And it can be debilitating. It can be, I think psoriasis has one of the highest rates of depression associated with it, because it's just so hard to beat sometimes. But we have a lot of good treatments now. So I always recommend, I put it out on my social media, if you have psoriasis, get into your dermatology provider, because there's lots of things we can do for you.
Yeah. So when we look at the treatments for these, there's a lot of different things you can do at home. The best thing you can do is just focus on products that are going to help to restore the skin barrier.
Yep.
And so when we talk about that bricks and mortar model, you have lotions and creams that have lipids, ceramides, cholesterols, fats that are going to help to augment the mortar in your skin and replace some of the things. Because when you have eczema or atopic dermatitis, your body's not as efficient at producing ceramides.
Right.
That process is impaired. So you can supplement those into the skin.
Yeah.
And you're going to be focusing on repairing the barrier. Psoriasis lesions also have that barrier dysfunction where moisturizers can help. And that's where also you can put in, some salicylic acid in the moisturizer or urea to help remove some of that excess skin. Hives, moisturizing is generally going to feel good for my hive patients.
Yeah.
I tell them, put your moisturizer in the fridge because that cooling effect is usually going to feel good.
Totally. And then my go-to for hives is go for the antihistamines, the Zyrtex or the Claritins. They're supposed to be non-drowsy, but definitely does make people drowsy. But
I have a few patients that complain of it, but most people I don't.
Most people don't
get drowsy.
I'll take 2 sometimes, but typically recommending that. Over-the-counter like Benadryl just doesn't really touch it, I feel like, for hives, but you can try it. And then when you're talking about eczema and psoriasis, you could try over-the-counter hydrocortisone, especially on the sensitive areas of of the face, like the cheeks or upper eyelids, things like that.
Yeah,
is a good option as well.
But at home, you don't want to use over-the-counter steroids for long periods of time.
Totally.
If you're not seeing
Sparingly.
things improve rapidly within, 3 to 7 days, and you're also using a moisturizer, then you probably should be seeing your doctor or a dermatologist.
100%.
We have non-steroid options that will help to resolve the rash without putting you at risk for steroid withdrawal or thinning of the skin or any of those potential complications.
Telangiectasias,
And I should probably say this about the antihistamines. As Austin mentioned, we call them second-generation antihistamines. That's your Zizal, your Claritin, Allegra, Zyrtec, that are non-drowsy. But they also do not come with anticholinergic side effects. We talked about acetylcholine in our Botox episode.
Yeah.
But Benadryl and hydroxyzine, which is available by prescription, have very strong anticholinergic side effects. So people can get dry mouth and they get very tired with these. In fact, hydroxyzine is sometimes used as a sleep aid.
Yep.
Not so much anymore, thankfully, but more and more data is coming out that the non-sedating second-generation antihistamines are just as effective, if not more so, than managing a rash or hives. And when you take Benadryl over long periods of time, it can increase your risk for developing dementia. Just with that acetylcholine interruption.
And it's taken very frequently, almost nightly, by people who are struggling to sleep and things like that.
And many over-the-counter sleep aids, if you look at the active ingredient, it's just Benadryl, or diphenhydramine.
Yep.
And, it's probably okay to take periodically, but if I, am traveling and my time zones are way off and I need a sleep aid, I may take a Benadryl, but I never buy the sleep aids because they're
ZzzQuil
4 times as expensive. And the active ingredient is just 25 milligrams of diphenhydramine. And you can buy like a bottle of diphenhydramine for $3.
Yeah.
So there's a little tip for you.
Great marketing.
Yeah. So let's talk about the prescription treatments a little bit. We talked about the over-the-counter moisturizers, over-the-counter hydrocortisone, which you can get at 1%. Prescription treatments, for most of these rashes, steroids are still our go-to.
Topical steroids will be the go-to. Oral steroids can be prescribed in really severe cases, especially in allergic contact dermatitis. You kind of need that. But most of the time, mid-potency to high-potency topical steroid used sparingly in conjunction with moisturizing the skin will knock these out.
Yeah. Even though these steroids come in creams and lotions and they feel like a moisturizer, they will not hydrate the skin.
Yeah.
They will actually weaken your skin barrier with continued use. And so you can avoid some of the risks of steroid side effects by using a moisturizer daily.
Yeah. And sometimes I've even mixed in steroids with like a big jar of CeraVe and like a clobetasol solution mixed together to try to do both. But we tell them not to use that for too long.
Not for too long.
It'll thin the skin, but those are typically the go-to options. We used to say in my first practice they have a clobetasol deficiency when people came in with just raging nummular eczema. But yeah, those are, and for people who have chronic ongoing atopic dermatitis or eczema, now hives, there are other types of medications aside from topical medicines, one being Dupixent, which is a biologic injection. And that was life-changing when that came out for a lot of people who just topical steroids and creams and everything else that we had just wasn't touching their eczema.
Yeah.
Dupixent has been a great option for people.
And now, in addition to Dupixent, we have Ebglyss, we have Adbry, and these are all injections every 2 to 4 weeks.
Nemluvio.
And Nemluvio, they interact on different chemicals in the body. We call them cytokines. So Dupixent hits interleukin 4 and 13. Adbry is an interleukin 13.
Yep.
I think that Ebglyss is an interleukin 13. And Nemluvio is an interleukin 31, which more specifically targets itch but does reduce inflammation in the skin. So they all have their pros and their cons. They're all very expensive. We have to get approval by a patient's insurance company to get them covered.
Right.
And we do that while we're also looking for underlying causes and trying to avoid triggers. Because my approach is I don't necessarily think patients want to be on these for the rest of their life, even though the pharmaceutical companies would love a lifetime customer. But if we can get things resolved, maybe we're changing the diet, maybe we're changing their daily habits, their stress levels. And when we get things really settled down and they've been stable for a long time, I'm generally supportive of taking a patient off the medicine and seeing how they do on a case-by-case basis.
Yeah. And there's data showing that when they're clear and you take them off, they stay clear for a very prolonged period of time.
Yeah. Now, there's also topicals that are steroid-free. These are going to be our topical calcineurin inhibitors. And these are anti-inflammatory, but they don't carry the side effects of steroids. There's also a topical JAK inhibitor, and this is called Opzelura. And just because we're saying these brand names doesn't mean we're getting any pharma kickbacks for it.
I know.
But Opzelura has been really helpful for our patients with eczema. Vitama and Zoryve are approved for psoriasis. I think Vitama might be eczema now as well.
Vitama got the eczema FDA approval recently.
So if you are leery of steroids or you've been on them for a while, there are options available. Speak with your dermatologist about the non-steroid options. And I always give these to patients if they have facial eczema or facial psoriasis. We try to manage it with that before we look at steroids for the face.
Totally.
So as we wrap up the prescription treatments, we'll take a little side quest and cover some trivia. So a little did you know?
Well, did you know? Here we go. So poison ivy, when people get a poison ivy rash, they get that, it's called allergic contact. They're usually allergic to the oils from poison ivy. And people think that it's contagious. It's not unless they don't wash the oils off. And if the other person or someone else touching those oils, it can spread to that person.
Yeah. So the fluid that comes out of the skin is not contagious.
The fluid's not contagious.
But if you think you've been exposed to poison ivy, the best thing that you can do is wash with soap and water. And that's enough to remove the oil off of the skin. It binds that oil and takes it off. And people can continue to get re-exposed because maybe they didn't clean the gloves that they were wearing while they were working in the yard, or the clothes that they were wearing, the boots. And sometimes it's the dog. The dog was running through, and they get the oils on their fur, and that doesn't bother the dog because it's not getting to their skin.
Yeah.
But the dog's coming inside, and you're petting it, and you keep getting re-exposed.
It's always the dog.
And then if you're out working in the yard, I have seen this in the clinic, and it's the worst thing, is somebody is working, they've touched poison ivy, and guys, this is a known fact.
I've seen this.
When you get the chance to go to the bathroom outside, there's no people around, guys will do that. And if they've got the oil on their hands and they go to the bathroom outside, I've seen people come in with poison ivy in the genitals, and it is awful. And we are definitely reaching for systemic steroids to calm that down.
Yeah.
So be very careful if you're working around plants you don't know in the yard or out in the country.
Yeah.
So, well, let's talk about eczema a little bit. Eczema comes from a Greek word that means...
To boil over.
Eczema comes from a Greek word that means to boil over. Because sometimes when we see eczema on the skin in an acute contact dermatitis, we see blisters, we see weeping and oozing of the skin, and it looks like something is boiling up and over the skin.
That makes sense.
So kind of just, terminology throwback.
Yeah. I love a little etymology lesson in there, but that's interesting. It does look blistery and bubbly and boiling.
Yeah.
So.
And we see it a lot this time of year as people start cleaning up their yards.
Yep. They're going outside, cleaning up the yards. The weather's changing. It all shows up.
So, well, that's a little did you know. Let's get into some rash prevention, management, and when you should see a dermatologist. So the easiest way to treat a rash is not to get it in the first place.
Yeah, avoid the thing
that
causes the rash.
So we talked about laundry detergent, and I will actually cheer the day that I discover laundry detergent caused a rash for somebody.
I can maybe think of one time in 10 years that it was the detergent.
So best practices to avoid the things that will damage your skin and give you a rash is gently washing your skin daily, using a hydrating body wash in the shower.
Yeah.
Gentle facial cleansers.
Dove soap is just a classic.
It works really well.
It works great.
It's not going to strip your skin. And then moisturize after bathing or showering.
Yep.
Something to help repair the skin barrier, because every day it's getting insulted and it just takes the right time. You're going to tip over.
Yeah. The way that I'd always learned it and the way that I still see it today is when you take a shower, your body's able, or a bath or whatever, your body's is able to soak up some moisture into the skin. But if you live in really dry climates or really hot climates, lots of times it'll evaporate pretty quickly. And so when you put on the moisturizer, you're essentially locking in the moisture. You're preventing the ability to lose the moisture, especially if you're prone to eczema, prone to psoriasis, or conditions that have barrier dysfunction. So the most important thing that I tell my patients to do when they come in is moisturize after the shower. That's the best time to do it. When you wake up in the morning, you get ready for your day, you put moisturizer onto your dry, flaky skin. Are you moisturizing your skin?
Am I? No, I'm actually not good at it.
Yeah.
So,
well, is it moisturizing to the skin?
Oh, is it moisturizing to the skin? Yeah. I mean, it does help. I think it is better when you can do it after bathing or showering.
Yeah.
But I definitely notice if I'm working all day, because I wash my hands a million times a day seeing patients, if I put on a good moisturizer, even if I haven't just washed my hands and they're not damp, I mean, it helps.
Yeah.
It helps significantly.
Yeah. Sometimes I hear people say, oh, it's not doing anything to put moisturizer on to just dry, flaky skin. It's like, it helps.
Yeah.
It helps. But you don't do it in the morning.
No, I don't. I don't do it in the morning. If I start, doctors make the worst patients. And so I am guilty that I moisturize my face regularly.
Yeah.
My hands semi-regularly. My feet semi-regularly, and my heels are atrocious.
Oh, yeah.
Because I love to wear sandals, as you can see for those watching the video. I wasn't seeing patients today, and I just wore sandals into the clinic. And, but otherwise, I'm not moisturizing a ton unless I start noticing that my skin is dry. And I know that's not the right way to do it, and that's not how I counsel my patients. But I understand the real world also, the way that patients are going to use these things. It's very similar to the way that I use them.
Yeah. I have to. If I am not moisturizing in the morning, especially, I'll take my socks off and it's just like caked in dead skin. I'm just a flaky guy.
You're making the snowstorms and you rip your socks off.
I'm flicking my socks off at my kids at night.
So people turn to home remedies all the time to try to help the rashes. And, maybe we can rate these like, is it good or bad? But essential oils.
Essential oils. I am never a fan of essential oils. Essential oils are made from usually plants or things found in our environment, and plants oftentimes have a high allergy rate, so that you have a good chance of becoming allergic to the essential oil. And the oil vehicle itself may be good in locking in moisture, but I don't recommend people to use essential oils.
I'm the same way. I remember a guy in residency who he started to develop a rash. I can't remember if it was shingles or what was going on, but he started putting on like eucalyptus oil. And the rash that was isolated to his shoulder was now running down his arm, and you could see streaks from where the essential oils would drip. And he developed a rip-roaring contact allergy to the essential oils.
Yeah.
And so we don't recommend those. If you are doing it, they should be diluted. And that really should not be your primary treatment. It's not dermatologist recommended.
No. I can't think of any time I've thought you should use an essential oil for that.
All right, next one, adding a little bit of bleach to the bath water.
Oh, that's a great one for people who struggle with eczema or psoriasis where that barrier dysfunction breaks down. Not a lot of bleach, so usually it's like a quarter cup per full bathtub. But that'll help kill bacteria, prevent infections in people who have barrier dysfunction. I recommend it to people who struggle with atopic dermatitis, little kids even who have eczema and they're getting infections left and right and they can't get under control. Is a great option for those people.
And it essentially turns it into about the concentration of a swimming pool.
Yeah.
And I still recommend, all right, you bathe them in that, then go ahead and just rinse them, pull the shower head off, rinse them off, and just get the chlorine off the skin, and then moisturize after the bath. But that can be a good way to help remedy a little bit of atopic dermatitis because we're essentially trying to balance the skin microbiome and get rid of the types of bacteria that will lead to infection.
Right.
Oatmeal baths.
Oatmeal baths. I have no problem with oatmeal baths. Use the oatmeal bath. It's probably pretty hydrating, and your skin's gonna love. People love how it feels. It's kind of like a soft feeling to the water. So I recommend people take oatmeal baths if they like doing that, and I have no problem with it.
Yeah, I mean, people can do it on their own, but Aveeno sells little kits. You just dump it in the bath, and you get that colloidal oatmeal. It's very good for the skin barrier. Any other home remedies that you've had patients use?
I'm trying to think. I can't think of any other ones besides oatmeal baths, bleach baths. Essential oils is the big one.
Beef tallow.
Oh, beef tallow. Beef tallow is a up and coming trend.
Yeah.
So who do we want to offend is the question. Beef tallow, it's probably very good at locking in moisture.
Yeah, it's good occlusive.
It's a good occlusive. Maybe too occlusive for the face because it could be comedogenic. For people who are prone to acne, it may cause a little bit of a flare if you're blocking the pores and things like that.
Yeah.
Arms, legs. If that's your jam, go for it.
Yeah, the way that I approach it is these companies, do they have a standardized way of making it? Are you getting the same product every time you're repurchasing it? I don't know that that's the case.
Or making it at home.
Or making
That's
it
a
at
trend
home.
now.
You also are taking something because it does have, fatty acids in there that can be good for the skin, but it's not always balanced. You're not getting ceramides in there. You're not getting the different things that a well-formulated body cream has.
Right.
And when it's trendy like this, people approach it as the panacea, the cure-all. Like you have to get rid of all of these other things because you need to go all natural.
It's natural, it's
and
pure.
It's not always the case. Same with coconut oil. Has some benefits. I generally don't mind if people are using it, if that works for them. But it's not the thing that I'm going to recommend in the clinic.
Yeah. I've never recommended beef tallow. Probably never recommended coconut oil because there are things that are more regulated and work just as well that
If not better.
that are not just following a trend. I hope my wife's not listening.
She on the coconut oil train?
She's the beef tallow train.
Beef tallow.
Oh, yeah.
Oh, maybe we should have her on the podcast.
We should.
Get her view. All right. When is a rash more than just a rash?
There's a few instances when there's more, when a rash is more than just a rash. So a lot of times people will come in. There's one that we see called dermatitis herpetiformis, where people get these little blistery. It's one of the itchiest things that we see in dermatology, maybe outside scabies, where you get these blistery, almost looks like herpes bumps on the elbows, the knees, and sometimes the buttocks. And that can be a sign that you have celiac disease and it's kind of uncontrolled and it's flaring.
Yeah. And this is something that doesn't generally respond to most of the treatments that we've talked about.
Exactly.
If you're still being exposed to gluten, then you're going to have, and it often will come with upset stomach, digestive issues, GI issues, and then you're getting this intensely itchy rash that nothing seems to touch.
Yes. And you're awake, you can't sleep, it's miserable.
Until you go gluten-free, it's not going to go away.
Yeah.
Then we have something that is called mycosis fungoides or cutaneous T-cell lymphoma.
Yep.
And this is something where patients go years on average before a proper diagnosis. This is a type of lymphoma of the skin. It looks like eczema. It looks like atopic dermatitis.
It mimics eczema.
And it's usually going to be in what we call the double covered areas or the bathing suit distribution. So it's common on the thighs, the hamstrings, on the buttocks, the lower parts of the abdomen and the trunk.
Yeah.
And it's just persistently itchy, scaly. It doesn't bother people a whole lot
No, it's very
unless
faint
it starts
sometimes.
to get advanced, because you have these faint patches, but they can develop into nodules and then tumors. And if it progresses enough, this lymphoma, which is limited to the skin, can transition and start to impact your lymph nodes inside your body. It can spread. And most people live with this condition and die with this condition, but not from this condition.
Right.
But there are times where it transitions into a much more aggressive type of lymphoma that can be life-threatening.
Yeah.
So it is important to treat. And this is the kind of circumstance where a patient comes in, it looks like eczema, they've been on topical steroids, it keeps coming back, it's mildly irritating, and this is the time to do a biopsy and determine, are we missing something here?
Exactly right. There have been many times where we see that case where they just have this persistent eczema kind of on the buttocks or hips, and it's just just never seems to go away. Do a biopsy and it comes back as mycosis fungoides. I think the onset or the typical time frame that people live with this before they have an accurate diagnosis is about 7 years.
Yeah, that's my recollection.
Yeah, and which speaks to how non-aggressive this condition is, but we need to get a good diagnosis. We need to treat it. So this is an exact time when we need to do a biopsy. Very often with dermatitis herpetiformis, again, good idea to do a biopsy because it can be diagnosed that way.
Another time when a rash is not just a rash is when we have hives and they're staying in an area longer than 24 hours.
Yeah.
Because this could be a type of vasculitis or inflammation of the blood vessels. We call it urticarial vasculitis because it looks like normal hives, but they can be more painful, more itchy, and they just stay in these areas for a much longer period of time.
Yeah.
If your hives are associated with swelling of your lips or tongue or swelling around your eyes, this is called angioedema, and this may indicate a genetic deficiency of something called complement in your body, which is part of your blood clotting system and your temperature regulation. It has a lot of different things, and that needs to be treated because it could eventually compromise the airway.
Right.
If you're getting hives or facial flushing and it's associated with gastric distress, like all of a sudden you got to go to the bathroom bad or you're vomiting, then you could be suffering from pheochromatosis or other types of angioedema that are affecting your internal organs, your adrenal glands.
Right.
And so that is one of the things I love about dermatology is that it's not just the skin. We actually study, learn, and treat a lot of the stuff that's going on inside the body.
Yeah. An interesting case that I had when I was first starting off, a lady came in and she had this vascular rash on her feet, non-palpable little blood vessel-y purpura. I did a biopsy because I wanted to make sure it wasn't HS, hand-actionolone purpura, or leukocytoclastic vasculitis, and it came back as vasculitis. But we used to send our pathology to UCSF, very academic pathology place, and they said there's one line at the very bottom. They said this could be a precursor to viral meningitis. And I had never read that or heard that, but I happened to mention it. I read it to her and I said, so if you get like neck stiffness, go to the ER. She came back 3 weeks later and said, 2 days later, I couldn't look down.
Oh, wow.
I went to the ER and I had viral meningitis.
That is wild.
And I was like, they called it. They got it.
That is a good read from your pathologist.
I know. I was blown away, but
Wow.
I'm glad that I read it.
Yeah.
I was like, sometimes it's like, oh, it's vasculitis.
Yeah.
You know, that's just fine.
Yeah, it's important not to just look at the top line diagnosis.
Yeah.
So in these conditions, first off, if you have a very regular rash that we talked about early in the episode that's not resolving with your at-home treatments, go see a dermatologist.
Yeah.
If you're having any of these other rashes that are accompanied by systemic symptoms, go see a dermatologist.
Right.
So seeing a dermatologist, that's when it's a good idea to take pictures because some of these rashes wax and wane, and it can be helpful if you come in without anything to show us, if we can get a better history from the photographs that you've taken. And then managing stress, I think, is another part that's important because every one of these that we've talked about generally can get worse if you're stressed.
They 100% can. Very often we see people who struggle with eczema, struggle with psoriasis. They will see flares when they're undergoing some sort of stress. And life happens. Sometimes it's hard to cope or to deal with what's been going on. But if you're struggling with these conditions, go see your dermatology provider because we can help control these while you're going through your stressful time.
Yeah. So as we wrap up today, we want to introduce you guys to the product of the week, and this is the La Roche-Posay Lipicar AP plus M. This is the triple repair moisturizing cream. La Roche-Posay has been around for a long time. They are a French pharmacy brand, and they use prebiotic thermal spring water in all of their products that helps to promote a better microbiome, better bacterial diversity on the skin. This is going to be a type of moisturizer with shea butter, niacinamide, ceramide 3. It is fragrance-free, so it's got nothing in there that's going to irritate the skin, and it's got all these different ingredients that are going to help repair and rebuild that skin barrier. And we'll have a link to this in the podcast show notes and in the video version on YouTube, where you can get a discount on purchasing this product through the Air Skin Store. And when you sign up for a free account on the Air Skin Store, you get discounts for life. So anytime you go back to repurchase, you will continue to get a discount cheaper than you can get it on Amazon, Target, Walmart, anywhere else. So we're big fans of La Roche-Posay. We recommend them all the time in the clinic. And if you have some sensitive skin, it's a great way to go.
Totally.
Thank you for tuning into this episode of Skinfluence. I'm Dr. Dustin. You can find me on all social media platforms at Dr. Dustin Portela. And Austin, where can we find you?
You can find me at Austin Lee, PAC, on Instagram, TikTok, and YouTube.
Thank you so much for listening to this episode. Please leave us a 5-star review and share this podcast with friends. We also have an Instagram account at skinfluence_pod. So send us your topic suggestions, ideas, and questions on the Instagram account, and we'd be happy to try to address those. Maybe we'll have to start adding a audience questionnaire section of the podcast.
I'd like that.
Try to answer you guys' questions. So thank you, and we'll see you on the next episode.